any angle surgery, seeing the angle is the most important. So visualization, crisp visualization is very important. That's why I usually will perform the MIGS procedures before doing cataract surgery, for instance. That way there's no corneal edema. Proper patient positioning is very important as well. What's great about the iTrack Advance is the spatulated cannula. So one will make a paracentesis directed towards the nasal angle. The spatulated cannula will permit the probe to insert into Schlemm's canal, and it also has amazing features such as the 360-degree rotational nozzle. That nozzle, for instance, if you want to switch from your right hand to the left hand, can change the angle. As you're advancing with the slider mechanism, it's very important for the patient not to feel pain. If a patient feels pain in any angle surgery, you're not in Schlemm's canal, you're probably in ciliary body. What's nice about the device itself is that you can retract the device if you're not in proper position. The illuminated tip will then go around 360 degrees. And as you're retracting that tip, you'll try to get at least 40 to 60 clicks in total over 360 degrees. Canaloplasty we've been performing since the old days. We were doing ab-external canaloplasty with the original iTrack device. We were also using proline sutures using GAT. But it's been almost, I would say, 8 to 9 years. In the last year, we've switched completely to iTrack Advance. The reason being is that easy insertion with the spatulated cannula and that lever where you just send it forward. I actually think that it improves safety for patients as compared to the original device. One thing that I've changed using the iTrack Advance is trying to use, when done in combination for a GAT procedure, for instance, I try to use a hands-free gonioprism. The reason being is with your dominant hand as you're sending that device forward, and if you want to go into the anterior chamber with your second hand, having something like the Gonio Ready or another hands-free gonioprism is one of the major changes I've done. I've also made sure that I'm giving enough clicks per quadrant. At ESCRS this year, we're presenting a paper from the International Glaucoma Registry. In that paper, we found that the amount of viscoelastic volume, the more you inject, the lower the patient's pressure. So probably you would want to get at least 40 to 60 microboluses as you're doing your 360 degrees. And I've paid attention to that to make sure that we're really dilating the entire outflow system, as well as creating those small microperforations through trabecular meshwork, which will permit then aqueous to use those different mechanisms of action to lower the patient's pressure. In general, you want to pick patients that don't have high episcleral venous pressure. That's a given. If you see anyone with any angle abnormalities, that may mean some PAS, increased angle pigmentation, you know that the disease is really at the trabecular level. That may be your best bet for doing any angle surgery. If your patient has normal tension glaucoma and is progressing with pressures of 15 and there's no angle pigmentation, the angle looks normal, that's probably not your first ideal patient. So I would pick someone whose pressure is slightly above target or at target that want to get rid of their medications. And often in combination surgery, one can get IOP coming down to the mid to lower teen range if you look for those type of patients. What's nice about this technique is, yes, we will address that trabecular outflow by creating those microperforations, but we're also very similar, I'll explain to a patient, very similar to cardiology, where we really want to dilate the distal vessels as well. That will also help lower the patient's pressure long term. Any patient with glaucoma, especially if it's progressive, we really want to target lower pressures. In the past, people felt that doing angle surgery, we may not be able to achieve those pressures. I was quite impressed when I saw in Journal of Glaucoma the publication showing 3-year results that we can really achieve low pressure as well as medication reduction in our patients. So I use that study to tell our patients and say, yes, after several years, we will be able, in the majority of cases, statistically speaking, to bring your pressure down to the mid to lower teen range, where we feel your glaucoma progression will probably stop or slow down. And an additional benefit, those drops that you're using several times a day that are irritating your eye, that you're forgetting, we'll try to get you off as many medications as we can. Traditionally, when going into the angle, often patients are weary of one of the complications, which is hyphema. One of the advantages of using the iTrack system is as we're viscodilating the entire system, we're decreasing that amount. So I'll tell a patient, probably for the next 2 weeks, we'll ask you not to bend low or lift heavy objects. They may still expect to have a little bit of hyphema. I encourage them saying that even if their pressure is slightly high on the first day, that may not necessarily be a bad sign if they have a small pressure spike. And usually then we'll taper their medications. Personally, I do not use steroids for a very prolonged time. We know that in any angle surgery, the more steroids you use, the more likely you are to have an IOP spike. So we'll usually taper those off over 2 weeks and keep patients on anti-inflammatory drops for a month.